Hello everyone. In this video, we will talk about a very important topic from orthopedics, which is important from both the theory point of view as well as from your competitive exam point of view, and that is osteoclastoma or giant cell tumor. Now, osteoclastoma or giant cell tumor is a locally aggressive tumor, which means it is locally invasive, okay, and it is a benign tumor. So, by nature, it is benign, it is not malignant. It occurs as a solitary lesion. So they're not multiple tumors, it's just one single tumor that happens in the bone, and it is lytic in nature, which means it will cause a lysis of the bone that it occurs in. Okay. And the main age group that we observe it in is 20 to 40 years. So, sort of young adult age group. And this is seen after epiphyseal fusion. So this is what you have to remember. This is after epiphyseal fusion in patients of age 20 to 40 years. Now, if we talk about the location, we know that for every bone tumor, this thing is really important, that which part of the bone it's happening in. And for giant cell tumor, it's epiphysis. So giant cell tumor takes place in the epiphysis, and that too in the epiphysis where the epiphyseal plate has been closed, so in adults. Okay. And if we talk about the bones that are involved, it most commonly occurs in the lower end of femur, upper end of tibia, and the distal radius. So lower end of femur, upper end of tibia, which are your corresponding bones above and below, and the distal radius. These are the three main sites, but then it can happen in other bones as well. Now, if you look at the clinical features, it happens mostly, like I said, in a young adult of age 20 to 40 years, and they will present with swelling in the bone, pain, and there might also be a complaint of pathological fractures. Since it's a lytic lesion, it will cause pathological fractures. So, a young adult with complaints of swelling, pain, and pathological fractures. What we see on examination is a bony swelling at the end of the bone. So, whatever this bone is, whether it's the femur or the tibia or the radius, it's always at the end of the bone. Okay, so it presents as a bony swelling at the end of the bone, and if we palpate it, there will be tenderness, which means the patient will complain of pain when we palpate. And then there's also a characteristic examination feature called eggshell crackling, which is seen in giant cell tumor. So there will be a swelling, tenderness on palpation, and eggshell crackling, which is a characteristic sign. Now, if we talk about the diagnosis, the modality that we use is X-ray or radiographical diagnosis, in which what we'll see is a solitary lytic lesion. A solitary means it's a single lesion, and lytic means it will cause lysis of the bone that it happens in. And the characteristic appearance that it shows are the soap bubble appearance. So why it appears like a soap bubble is because it the trabeculae of the bone are seen separating the cavity of the tumor, so it appears as a soap bubble appearance. It appears loculated basically. So if you look at this, you can see these little trabeculae separating the entire cavity of the tumor. So it's looking like these little bubbles of soap. So if you look at soap, it creates bubbles, right? These little bubbles are seen in giant cell tumors. This is called soap bubble appearance. And this happens once the epiphyseal plate is closed. It happens in the epiphysis, the distal part of the bone, and it happens after the epiphyseal plate is closed. So in adults, you can see this epiphyseal plate has been closed, you can't see a separation. Okay. Then it's eccentric in location, which means it's not going to be in the center, it's going to be away from the center at the end of the bone. If you look at the cortex, it is expanded and thinned out. The entire cortex will be expanded and it will be thinned out, the margins will be thinned out, and there is no calcification that we see inside this tumor. So these are the diagnostic points of in X-ray. It is a solitary lytic lesion, showing a soap bubble appearance. The epiphyseal plate is closed, it is eccentric in location, the cortex will be expanded and thinned out, and there is no calcification which is seen inside the tumor. If we take a biopsy, pathologically, if we look at the tumor, there will be giant cells. If you can see here, these are the giant cells. Now, giant cells, we know from pathology that they are multinucleate cells. Okay, so giant cells are usually multinucleate, multiple nuclei are present in giant cells, and the bone the cells in the bone which have these multiple nuclei are called osteoclasts. So these giant cells will look like osteoclast, so they will be multinucleate osteoclast like giant cells in the tumor, and these cells will be surrounded by these little mononuclear cells. So these are multinucleate, the giant cells are multinucleated, but they will be surrounded by mononuclear cells. Now, what we have to remember here is that the tumor cells are the mononuclear cells and not the giant cells. Even though the name of the tumor is a giant cell tumor, but the tumor cell are these mononuclear, these single nucleus wale cells that surround the giant cells. Those are what the tumor cells are. Those are what comprise the tumor basically, or form the tumor. If we talk about the treatment is by extended curettage. We do a curettage of the bone, and that cavity is filled up with liquid nitrogen or bone cement. Otherwise, an excision of the tumor can also be done, followed by reconstruction of that part. And if excision is not possible, radiotherapy is done. Now, if we talk about the prognosis, there is a risk of malignant transformation of the tumor. It can convert into a malignancy, and that risk is 5%. There's a 5% chance of malignant transformation. And if this malignant tumor metastasizes, it goes mainly to the lungs. This is the main point of metastasis. And there is a high chance of recurrence also for this tumor.